about this, so you need a good video scope so that you can see clearly where you want to inject. So biomaterials that you can inject for injection laryngoplasty. You can choose from different short-term and longer-lasting materials. The one that we have in Malaysia is the hyaluronic acid. We use Juvederm Ultra XC. And longer lasting, we will use Radius Plus or calcium hydroxyapatite and also fat. This one we have in Malaysia, but other countries may have collagen in the form of Symetra, Zyplus or Zyderm, carboxymethylcellulose, Radius, Prolarynx, gel foam. Here we don't have this. Or long-lasting, probably fascia or bioplastic. We still don't have these in our Malaysian market. So far, we are happy with Juvederm Ultra Plus XC for our hyaluronic acid and also Radius Plus for longer augmentation. So this is a video showing how we give local anesthesia for patients undergoing a transthyrohyoid injection. So we give local anesthesia at the skin and the soft tissue at the superior thyroid notch there. You have to make sure that you are really at the midline. You don't sway yourself to the right or to the left, yeah? And then we will give intratracheal anesthesia at the lower border of the cricoid cartilage. So this is between the cricoid and the first tracheal ring. So we aspirate for air, you can see that. Once you have aspirated air, you confirm that you are at the correct space, and then we will give 4 mils of 2% lignocaine. This is the different bands that I'm showing you just now for us to deliver the injection through the transthyrohyoid route. We use a double band needles, different configuration for different gender. So once the needle is passed through the petiole of the epiglottis, you can see this one is slightly not at the midline, slightly more to the right side, but still we could have access to the paraglottic space to perform the injection laryngoplasty. So you can see the injection is being done just anterior to the tip of the vocal process. Needle is in, then we give a test injection about 0.2 mils to make sure that we are at the correct space, and you can see the medialization that will occur from caudally going to cranially. So the medialization, you can see there bulging at the lower border, undersurface of the vocal fold, and then slowly it progresses cranially, and you can see that this is a good medialization that you can achieve for this patient with unilateral vocal fold paralysis. So we try to augment and get 10 to 20% over medialization because some of this biomaterial will be absorbed by the body. Yeah? So after the procedure, generally we will ask the patient not to eat or drink within 1 hour. And then after that, if you have high-risk patients, you monitor them for longer durations. So 30 to 60 minutes for high-risk patients. That means patients with previous history of allergy or patients with significant cardiovascular problem. You can monitor them for a longer period of time. Yeah? Then we ask the patient to start vocalizing at 2 days post-procedure. So after the injection laryngoplasty, no speaking, no whispering. The patient can cough, but then we don't ask the patient to cough. If they can try hold the cough, they will hold the cough. Yeah. So no whispering after 2 days, then they can start vocalizing. And then we will see the patients at 1 month post-procedure. Follow-up call is usually at 2 weeks post-procedure. So this is a picture showing the double band needle that we use for transthyrohyoid injection laryngoplasty. So the male needle basically has the first band at 45 degrees. The first band, the length is about 15 millimeter. For the female needle, the angle is 30 degrees and the length from the first band is about 10 millimeters. So we are able to get really good success rates in our cohort of patients of 81 patients. Overall success rate of 96.3%, and generally the same if we compare between males and females. If we were to compare between other authors in the literature, we feel that our success rate, although it's not 100%, but it's still a good number. So some pointers regarding bevel of the needle. So you may see in some of the videos that I put up, the bevel of the needle is facing up. and some of the videos, the bevel of the needle is facing downwards. So this is an example of a patient who has chronic unilateral vocal fold paralysis in which the vocal folds are really atrophic. So you can see that in this example, the bevel of the needle is facing downwards. We are using the double bend needle, okay? So it's very important for you to make sure that when you see endoscopically, you must be able to see the first bend, which is this one, yeah, all the time. So because the bevel is facing downwards, so you cannot gauge how deep you are unless you see the first bend. So if you see the first bend, then you know whether you are too superficial or too deep, because you can't see the bevel. So pay particular attention. If let's say your bevel of the needle is facing downwards, you must be able to see the first bend at all times. If you don't bend the needle twice, you do a soft bend, it's much more difficult for you to visualize and gauge your depth. So this is what happened to the patient. So initially, we are able to see the first bend. You can start to see the medialization. But after a while, when you place the scope downwards, so the operator might have gone too deep, and wait for it, you see that it's gone through, punctured through the vocal fold. Because you didn't pay particular attention to see the bend of the first bend at all times. So you may be too deep because you don't see the bend of the needle, okay? So some case examples and outcome. So this was the patient that basically you heard in the early part of the lecture. So you can see all the parameters pointing towards significant glottic insufficiency. We injected the patient with Juvidum Ultra XC, and at 1 week post-procedure, this is his voice.
Masa saya kecil, saya tinggal di kampung bersama nenek. Ayah dan emak tinggal di bandar.
Okay. So there's complete resolution of aspiration, some degree of roughness, still right unilateral vocal fold paralysis, but now in a favorable position. Yeah? So the maximum phonation time has improved, and we are now able to try to have a swallowing test in the clinic. So upon swallowing test in the clinic, bedside swallowing test, you can see that there is no aspiration and penetration. So we are able to take the Rouse tube out for the patient. Okay, so this is the video showing the injection laryngoplasty performed for the same patient. So we took the liberty of injecting both sides, initially the paralyzed side, just to fast forward a bit, and we also injected the contralateral side because you can also see some bowing on the left side. Okay, then this is the video of the patient at 1 week. You'll see some edema there, yeah? But you can see overall the vocal fold is already straight, and on phonation you can see that there is complete glottal closure. Yeah. Yeah. Okay. So our experience in office injection laryngoplasty in acute unilateral vocal fold paralysis. This paper was authored by Dr. Chow Ziao Hong, our postgraduate students. You can see that in our cohort of 29 patients, all the vocal parameters showed significant improvement. So it is very useful to perform injection laryngoplasty in patients with acute unilateral vocal fold paralysis. So please don't wait, because some surgeons manage acute unilateral vocal fold paralysis conservatively even though the patients are symptomatic. So please don't do this to your patients. If you can't perform office injection laryngoplasty, do refer to colleagues who can perform. So this is some of the videos showing patients undergoing injection laryngoplasty with chronic unilateral vocal fold paralysis. So in chronic unilateral vocal fold paralysis, you can see atrophic vocal folds here. Erythenoid is enteromedially prolapsed. Even if we have performed injection laryngoplasty in this setting, we managed to get some good medialization 1 month after some of the injection material has resolved, so we need to do repeated injections. At 6 months, even if with the injection laryngoplasty, you can see it's straight, the erythenoid position has improved, but still the patient has significant reduction in the maximum phonation time. This patient couldn't afford to perform type 1 thyroplasty. He is happy with his voice, so even though there is still some small glottal gap, he's not keen for thyroplasty yet. Okay. So for chronic unilateral vocal fold paralysis, injection laryngoplasty is less effective compared to patients with acute unilateral vocal fold paralysis. So this is my conclusion slide. Injection laryngoplasty is an effective procedure to treat glottic insufficiency, especially in the acute setting. In chronic settings, you may need repeated injections and the patient needs to think of permanent procedures. The use of the 21 gauge double bend needles has proven to be successful in the majority of our transthyrohyoid injection laryngoplasty cases. Thank you. Please post your questions on Slido.